This is Dr. Howard Strassler with an e-lecture on Decision Making and Restorative Interventions, Module B, Class 4 Anterior Proximal Carious Lesions, Defective Restorations, Traumatic Fractures, Class 4 Preparation Design. And here we're looking at an image of a Class 4 traumatic fracture. How are we going to manage this? What comes into mind? What are our considerations clinically when these things happen? Class 4 interventions for fractured anterior teeth really require a significant amount of evaluation. The patient presents themselves either directly to your office, or they may just call up and say, I broke a front tooth, I kissed the concrete when I fell, or perhaps they were hit in the face by a foreign object, a tennis racket, a golf club, or perhaps they walked too close to a swing set and the swing hit them in the mouth. We're going to have to do a really thorough exam. And this exam is not just looking at the teeth, but really a facial exam. Look for any lacerations that may be present. Make the decision whether or not it could have been a concussive injury that caused a fracture. Patient being hit on the chin, the teeth hitting together, and that causing a fracture. When we do our facial exam, we're looking for soft tissue lacerations, and in fact, we may decide the tooth is less important than the patient going to the emergency room to see a plastic surgeon to have lacerations stitched up and attended to. But typically what we see in the dental office are tooth fractures for the Class 4. Although Class 4s can be a direct result of a Class 3 restoration becoming so large that we need to now include the incisal edge, that typically Class 4 restorations are teeth that fracture due to trauma. We're going to do an intraoral exam, evaluating not just the teeth, but the periodontium, the alveolus. We're going to look at mobilities. We're going to see if the tooth has been repositioned and has anything happened to the occlusion. We're going to do a pulpal assessment, looking for pain. We're going to see where the enamel has fractured and where it has fractured as it relates to the pulp. After we've done our thorough clinical exam, and keep in mind it's not just the fractured tooth, but it's also the teeth that are opposing it. When someone breaks a maxillary central incisor when they're hit in the chin, that fracture may be a direct result not of the tooth being hit directly, but directly by the mandibular teeth. And in fact, anterior teeth that don't fracture are at great risk. After we've done our assessment of all the teeth that have been part of the injury, we're going to do a radiographic exam. We're going to evaluate for root fracture, evaluation of pulpal development on the younger patient who has a tooth that isn't fully developed. We're going to make some decisions as to how we proceed. The most typical fracture that we see of a Class 4 is an enamel-only fracture. The intervention may be merely reshaping and smoothing it out with discs and polishers. If the fracture is more significant and aesthetic, we may restore it with direct composite resin. There are times that the fracture is within the dentin and the enamel. When that happens, we're going to go in and restore with a direct composite resin, or we may make the decision that the fracture is so extensive that to restore, we may need some type of veneer or porcelain fused to metal or all ceramic crown. Part of our evaluation when making the decision how and when to restore is to whether or not the pulp is involved and there's endodontic involvement. And you'll be learning more about those types of assessments when you get into your endodontic course. But also in our case-based seminars, we're going to look at circumstances where teeth have been fractured and we need to take into consideration our facial exam, our periodontal exam, our pulpal exam, as well as our hard tissue tooth exam. We'll need to look at tooth alignments and occlusion as it relates to how we're going to proceed. In the most severe instance of fracture, a class 4 traumatic fracture, the tooth in fact may be unrestorable and need to be extracted. This is extremely traumatic, as you can imagine, especially since the teeth are in the anterior aesthetic zone. And the patient's going to want to know, how can I replace that single missing teeth? And we talk about tooth replacement of anterior teeth. We really have a number of different choices we have. And keep in mind, replacing an anterior teeth is aesthetic. It may be optional. The patient may not be able to afford to have it replaced. You'll see people who are missing front teeth, although it's hard to imagine someone wants to be seen that way. But when we think about replacing missing anterior teeth, similar to that with posterior teeth, although we are in the aesthetic zone, we think in terms of the treatment of using an implant to replace the tooth. We might consider replacing a 3-unit fixed partial denture using the adjacent teeth as abutment teeth to hold the pontic. We might make the decision to replace the missing tooth with a removable partial denture. So we have a number of different treatment options that are available to us to replace that tooth that's been unrestorable. So our decision making for class 4 when we're looking at restoring that fractured tooth. And with trauma there may be some extreme decisions. And those extreme decisions might be that we need to do some orthodontic extrusion for that tooth. We may decide that it's non-restorable and we're going to go in with a fixed partial denture or removable or implant. In this case, we're looking at an anterior tooth that's fractured on a teenager. The tooth has been endodontically treated. The tooth's going to get a cast post and core, and it's going to be extruded with orthodontic movement. As the tooth extrudes, the periodontium moves with it, and later, when the tooth is at the height we want it at, we're going to go in and do a periodontal procedure and do crown lengthening so that we can restore that tooth. So the decision making depends upon the severity of the fracture. It can be as minor as a small chip that can be recontoured to that severe situation that we just saw, where it's between extraction or salvaging the tooth and then making decisions as to what's the cost benefit, what's the prognosis. For this small fracture on the incisal edge of tooth number 8, the patient only wanted it smoothed off. We took a finishing disc, a soft wax disc, and finished it down, and then we polished it with a rubber abrasive. For me personally, I would have restored this with composite, and keep in mind, to restore it with composite, we need to do a significant tooth preparation. The more we need enough composite to be durable and stay in place in this anterior high stress bearing area. Subgingival fracture with endodontic treatment. Is it necessary to restore, or do we make the recommendation to extract? Keep in mind the anterior region has an emotional piece attached to it. And there are times when we will restore class 4 fractures. Here we're looking at a class 4 composite resin that's been restored and is fractured twice over a period of 4 months. The relative edge-to-edge occlusion must be changed to expect a more durable, long-lasting restoration. Or perhaps the composite's failing not because of occlusion, but because the patient's biting their fingernails, or perhaps they bite into ice or hard candy. And so when we're looking at class 4s, there are significant occlusal considerations. We need to look at centric occlusion. We need to look at mid-protrusive excursions and full protrusive excursions, edge-to-edge, and lateral excursions. That'll help determine whether or not we need to reshape opposing teeth so that we can rebuild the fractured tooth back to an aesthetic and functional circumstance. And so the decision as to how we restore fractured teeth. The use of composite resin or the use of a crown. And our decision making and the cause of most traumatic fractures is an accident, an isolated event. It might be a sports-related injury. Certainly fabrication of an athletic mouth protector for prevention is the goal, to preserve that tooth. Preservation of a restoration with use of athletic protectors once we have restored. And then I refer you to your endodontics course for the guidelines for pulpal evaluation when you see these traumatic fractures. You know, I spoke about athletic injuries being responsible for Class 4 fractures. In fact, dental injuries during athletic activities have been estimated to affect 15 million Americans annually. It's been estimated there's a 1 in 10 chance to suffer a facial dental injury during a single athletic season. And think of the sports where that could be possible. Basketball, football, ice hockey, field hockey, lacrosse. It could even be baseball with the ball coming up and hitting you in the mouth. Gymnastics, swimming, diving, even track and field. You could be tripping and kiss the pathway when you fall. And as I said earlier, that these injuries are preventable by using a custom fabricated mouth guard. Not a boil and bite that you get in the store, but one that's based upon casts we make of the patient's dentition. And so the small enamel fracture can be smoothed with discs and rubber abrasives. For the larger Class 4 fracture, as we see here, to teeth number 8 and 9, we can restore them with a direct composite resin to create what I refer to as invisible restorations. Our preparation designed for Class 4s, and this fracture we see on the distal of tooth number 9. That keep in mind, when I take a look at number 9 before I restore it, I'm going to talk with the patient about some things that I notice. First off, there's a diastema distal to tooth number 9. That number 8 is narrower, mesial, distal, than tooth number 9 is. Tooth number 9 is going to be wider. That this fracture is slightly within the dentin. This patient actually was on their bicycle and a car came along and the car won, the bicycle lost. Our preparation designed for Class 4s are intra-enamel chamfers or long bevels that are typically 1 to 2 millimeters long and half the thickness of the enamel. For tooth number 9, where in the incisal third the enamel is at its thickest, as compared to if we were at the gingival third, the enamel is at its thinnest, being 2 to 3/10 of a millimeter. So the enamel preparation gets narrower, thinner, less wide, buccolingually as we move towards the cervical. We need to be very wary to maintain the enamel. Enamel is our most retentive interface with adhesion. Our preparation designed for our Class 4 is an intra-enamel chamfer that we're looking at here that is 1 to 2 millimeters long and half the thickness of the enamel. We prepare the lingual surface with a chamfer as well to have a thickness on the composite in that stress-bearing area. We're going to use a thin chamfer diamond to create our preparation. You can see that I'm measuring the length of this preparation to be 2 millimeters. We know from research studies that the 2 millimeter length is critical to have our optimum retention in this stress-bearing area. What about when the patient fractures the tooth and they still have the piece of the tooth? Andreasen and his research group in Scandinavia looked at the long-term survival of tooth segments, tooth fragments that were bonded back to place, where the patient or the parent brought in the segment and fragment, and the fragment was rebonded. In this study, 334 teeth were treated with reattachment using an adhesive technique. The survival rate was 50% at 30 months and 25% at 90 months. The color match was perfect because, in fact, it was the piece of tooth. With enamel and dentin adhesion today, the retention rate is significantly better. And the critical factors determined to be successful for this study were the age of the patient, the ability to maintain the dry field, and a greater risk of second injury. If it's an athletic injury, the athletic mouth guard is critical. Keep in mind, if someone's playing sports that put the teeth at risk, they'll continue to be at risk. And so the preventive aspect of athletic mouth guards is very critical. So let's take a look at a circumstance. A young child has fallen, kissed the concrete, and has broken their anterior teeth. You can see the developing dentition. This child is approximately 7-8 years old. The mother came in with the segment of the tooth. The segment of the tooth was tried in after we did our full assessment of the periodontium, the pulp. The soft tissues looked for facial lacerations, and as you can imagine, it's much more difficult managing a child who has had a traumatic injury. At 9 months, when we rebonded the segment back on, it was still in place. You can see that segment at 9 months. What about a traumatic fracture with a pulpal exposure as we see here? And boy, that looks painful, doesn't it? That we look at whether it's an immature tooth versus a mature tooth. An immature tooth means that the apex hasn't fully formed, and an apexification procedure may be necessary. You'll learn more about the apexification procedure and the use of reagents within the canal for apexification. For the mature tooth, the older tooth, the tooth on the adult patient, our treatment will in some cases be endodontic treatment with a composite core, with or without a post, and followed by a crown. We can treat a tooth endodontically with or without a post and place a direct composite for a teenage patient where we want to wait before we place the crown. In this instance of an 11-year-old patient that I saw, they had an immature tooth. You could see that the apex is wide open. This tooth, in fact, had been fractured and had not been restored for 6 months. It was non-vital. Using calcium hydroxide, an apexification procedure was done. Now keep in mind, when we look at this number 8 that's fractured, one of the things I'd like you to notice is that when number 8 fractured, that its progression of development stopped as compared to the adjacent tooth continued. We had the loss of space due to this fracture near the gingival line, and number 7 and number 9 collapsed on that space because the proximal contact wasn't there. The tooth was treated endodontically with gutta percha, and then a fiber post was cemented in the tooth and a composite resin class 4 was placed to restore it. This fiber post happens to be radiolucent. Today's fiber posts are radiopaque. We noted the loss of space, and the recommendation was orthodontic treatment in order to create new space so the tooth could be restored. And we would need endodontic repositioning. And you think about in the future, if we're going to do a crown for this tooth, look at the root proximity on the distal against the lateral incisor. There'd be no room to create a margin to place a crown. So we need to include regaining space after endodontic treatment and restorative treatment for some time in the future. For this patient, we created room by reshaping number 9 and placing a direct composite. When this patient becomes an adult, we'll evaluate it for crown lengthening and for a crown and potential orthodontic intervention. Endodontically treated incisors with composite resins are going to need an intervention. In this case, for this patient, the endodontic treatment was done because there was trauma to the lateral incisor. It hasn't changed color. We replaced the existing class 3 composite resins. We place a fiber post and a composite core. And here we're looking at the crown preparation for an all-ceramic crown. In today's world, our all-ceramic crown in all likelihood will be a lithium disilicate crown. It could be a ceramic crown, although it could be a pressed ceramic crown that is made with a lucite reinforced porcelain. But we want to look and evaluate biologic width when the fracture compromises the periodontium. We're going to look at restorability, and the treatment options need to be reviewed with the patient. And in this case, the tooth is endodontically treated. It's sometimes hard at that moment when the tooth is fractured and the trauma has occurred for the patient to make logical decisions, so you keep them comfortable, and you can reschedule them at a time when you can talk about the option. Look about cost benefit, look at prognosis. For this patient, the idea of extraction of a maxillary central incisor was not tenable. They did not want to have that done. They wanted to do everything they can do, whatever heroic treatment was necessary to save this tooth. The decision to save this tooth was to do orthodontic extrusion. For this tooth, a cast post and core was made, and a temporary crown was cemented on using a definitive cement using a resin-modified glass ionomer. A button was put on the temporary crown, and orthodontic extrusion was done by placing brackets laterally on the adjacent teeth and placing a bend within the wire so that an elastic could be placed on the button, placed on the temporary crown, and that we could get extrusion of the tooth. Notice where number 8 fractured and endodontics was done. Number 9, although it didn't fracture, number 9 needed endodontic treatment due to the trauma as well. The cast post and core was made. In fact, this piece in the front, and this is a gold post, is the cleat of the cast post and core, so that the cement holding on and for the tooth movement is in fact the cemented posts. Arch wire, rubber bands were used to extrude the tooth. And notice that the tooth is extruding. Look at the difference between the height of the gingiva between number 8 and number 9. We've gotten that extrusion. After the extrusion was completed, the bone and soft tissue was recontoured and shaped so that the gingival free margin would be at the same height for number 8 and number 9. And at this point, 6 weeks later, an impression can be made and a crown preparation impressed and a crown fabricated. Post-surgery, the margins are then redefined. An impression made that this is 6 to 8 weeks after the procedure was the surgical procedure was completed. And so a subgingival fracture with endodontic involvement can be treated a number of different ways. Orthodontic extrusion was rejected by this patient. Post and core periodontal surgery was rejected by this patient. The decision was either an implant or a 3-unit bridge as treatment options. And so there isn't only one way to treat these severe circumstances, but you need to present the patient a logical course of treatment and include what prognosis will occur when those treatments are followed through. It really comes down to a successful diagnosis and treatment planning to evaluate using all diagnostic tests. Certainly in the case of the traumatic fracture, the periodontium may be affected. We may see an effect on the pulpal tissue as well as to the hard tissue. It may not be an easy decision, and keep in mind the final result to restore the class 4 needs to fulfill the patient's aesthetic needs and their demands. You've just been viewing and listening to Decision Making and Restorative Interventions, Module B, Class 4 Anterior Proximal Caries, Defective Restorations, Traumatic Fractures, and Class 4 Preparation Design. We'll be going through more in detail the techniques for restoring the class 4, and through your curriculum in fixed prosthodontics, removable prosthodontics, and operative dentistry, you'll see the different treatment modalities for managing class 4 fractures depending upon severity and level of treatment.